Pathophysiology of asthma. Asthma is a common pulmonary condition defined by chronic inflammation of respiratory tubes, tightening of respiratory smooth muscle, and episodes of bronchoconstriction. According to the World Health Organization, asthma affects 235 million people worldwide. There are two major categories of asthma: allergic and non-allergic. The mechanism of inflammation in asthma may be acute, subacute, or chronic, and the presence of airway edema and mucus secretion also contributes to airflow obstruction and bronchial reactivity. Varying degrees of mononuclear cell and eosinophil infiltration, mucus hypersecretion, desquamation of the epithelium, smooth muscle hyperplasia, and airway remodeling are present. See the on the IMS. Some of the principal cells identified in airway inflammation include mast cells, eosinophils, epithelial cells, macrophages, and activated T lymphocytes. T lymphocytes play an important role in the regulation of airway inflammation through the release of numerous cytokines. Other constituent airway cells, such as fibroblasts, endothelial cells, and epithelial cells, contribute to the chronicity of the disease. Other factors, such as adhesion molecules, IgG, selectins, integrins, are critical in directing the inflammatory changes in the airway. Finally, cell-derived mediators influence smooth muscle tone and produce structural changes and remodeling of the airway. The presence of airway hyperresponsiveness or bronchial hyperreactivity in asthma is an exaggerated response to numerous exogenous and endogenous stimuli. The mechanisms involved include direct stimulation of airway smooth muscle and indirect stimulation by pharmacologically active substances from mediator-secreting cells such as mast cells or non-myelinated sensory neurons. The degree of airway hyperresponsiveness generally correlates with the clinical severity of asthma. A study by Balzer et al. Reported changes in airway-resident mast cell populations from a large group of subjects with asthma and normal control subjects. A greater proportion of CHIMAS-positive mast cells in the airways and increased prostaglandin D2 levels were identified as important predictors of severe asthma as compared with other steroid-treated subjects with asthma. Chronic inflammation of the airways is associated with increased bronchial hyperresponsiveness, which leads to bronchospasm and typical symptoms of wheezing, shortness of breath, and coughing after exposure to allergens, environmental irritants, viruses, cold air, or exercise. In some patients with chronic asthma, airflow limitation may be only partially reversible because of airway remodeling, hypertrophy and hyperplasia of smooth muscle, angiogenesis, and subepithelial fibrosis, that occurs with chronic untreated disease. Airway inflammation in asthma may represent a loss of normal balance between two opposing populations of Th lymphocytes. Two types of Th lymphocytes have been characterized: Th1 and Th2. Th1 cells produce interleukin, IL-2 and IFN, which are critical in cellular defense mechanisms in response to infection. Th2, in contrast, generates a family of cytokines, IL-4, IL-5, IL-6, IL-9, and IL-13, that can mediate allergic inflammation. A study by Galva et al. Found that IL-13 has a role in allergen-induced airway responses. The current hygiene hypothesis of asthma illustrates how this cytokine imbalance may explain some of the dramatic increases in asthma prevalence in westernized countries. 7. This hypothesis is based on the concept that the immune system of the newborn is skewed toward Th2 cytokine generation, mediators of allergic inflammation. Following birth, environmental stimuli such as infections activate Th1 responses and bring the Th1/Th2 relationship to an appropriate balance. Airflow obstruction. Airflow obstruction can be caused by a variety of changes, including acute bronchoconstriction, airway edema, chronic mucus plug formation, and airway remodeling. Acute bronchoconstriction is the consequence of immunoglobulin E-dependent mediator release upon exposure to aeroallergens and is the primary component of the early asthmatic response. Airway edema occurs 6 to 24 hours following an allergen challenge and is referred to as the late asthmatic response. Chronic mucus plug formation consists of an exudate of serum proteins and cell debris that may take weeks to resolve. Airway remodeling is associated with structural changes due to long-standing inflammation and may profoundly affect the extent of reversibility of airway obstruction. Airway obstruction causes increased resistance to airflow and decreased expiratory flow rates. These changes lead to a decreased ability to expel air and may result in hyperinflation. The resulting overdistention helps maintain airway patency, thereby improving expiratory flow. However, it also alters pulmonary mechanics and increases the work of breathing. Bronchial hyperresponsiveness. Hyperinflation compensates for the airflow obstruction, but this compensation is limited when the tidal volume approaches the volume of the pulmonary dead space. The result is alveolar hypoventilation. Uneven changes in airflow resistance, the resulting uneven distribution of air, and alterations in circulation from increased intra-alveolar pressure due to hyperinflation all lead to ventilation-perfusion mismatch. Vasoconstriction due to alveolar hypoxia also contributes to this mismatch. Vasoconstriction is also considered an adaptive response to ventilation/perfusion mismatch. In the early stages, when ventilation-perfusion mismatch results in hypoxia, hypercarbia is prevented by the ready diffusion of carbon dioxide across alveolar capillary membranes. Thus, patients with asthma who are in the early stages of an acute episode have hypoxemia in the absence of carbon dioxide retention. Hyperventilation triggered by the hypoxic drive also causes a decrease in PaCO2. An increase in alveolar ventilation in the early stages of an acute exacerbation prevents hypercarbia. With worsening obstruction and increasing ventilation-perfusion mismatch, carbon dioxide retention occurs. In the early stages of an acute episode, respiratory alkalosis results from hyperventilation. Later, the increased work of breathing, increased oxygen consumption, and increased cardiac output result in metabolic acidosis. Respiratory failure leads to respiratory acidosis due to retention of carbon dioxide as alveolar ventilation decreases. Asthma treatment and management. Medical care includes treatment of acute asthmatic episodes and control of chronic symptoms, including nocturnal and exercise-induced asthmatic symptoms. Pharmacologic management includes the use of control agents such as inhaled corticosteroids, long-acting bronchodilators, beta-agonists and anticholinergics, theophylline, leukotriene modifiers, and more recent strategies such as the use of anti-immunoglobulin E, IgE, antibodies, omalizumab, anti-IL-5 antibodies, and anti-IL-4/IL-13 antibodies in selected patients. Relief medications include short-acting bronchodilators, systemic corticosteroids, and ipratropium. For all but the most severely affected patients, the ultimate goal is to prevent symptoms, minimize morbidity from acute episodes, and prevent functional and psychological morbidity to provide a healthy, or near-healthy, lifestyle appropriate to the age of child. A stepwise, step up if necessary and step down when possible, approach to asthma management continues to be used in the current guidelines and is now divided into 3 groups based on age: 0 to 4 year, 5 to 11 year, 12 year and older. For all patients, quick relief medications include rapid-acting beta-2 agonists as needed for symptoms. The intensity of treatment depends on the severity of symptoms. If rapid-acting beta-2 agonists are used more than 2 days a week for symptom relief, not including use of rapid-acting beta-2 agonists for prevention of exercise-induced symptoms, stepping up on treatment may need be considered. A study by Price et al. Randomly assigned patients to 2 years of open-label therapy with leukotriene antagonists, 148 patients, or an inhaled glucocorticoid, 158 patients, in the first-line controller therapy trial and a leukotriene antagonist, 170 patients, or long-acting beta-agonists, 182 patients, added to an inhaled glucocorticoid in the add-on therapy trial. 71. The results of these 2 trials suggests that a leukotriene antagonist is equivalent to both comparison drugs with regard to asthma-related quality of life at 2 months. But equivalence was not proven at 2 years. A Cochrane review found that inhaled corticosteroids are superior to antileukotrienes when used as monotherapy in adults and children with persistent asthma. The superiority of inhaled corticosteroids is most pronounced in asthma patients with moderate airway obstruction. The 2019 Global Initiative for Asthma, GINA, guidelines identify inhaled corticosteroids as the preferred controller medication of choice for children and adults. In general, patients should be assessed every 1 to 6 months for asthma control. At every visit, adherence, environmental control, and comorbid conditions should be checked. If the patient has good control of their asthma for at least 3 months, treatment can be stepped down. However, the patient should be reassessed in 2 to 4 weeks to make sure that control is maintained with the new treatment. A study by Brazis et al. Assessed the asthma self-management for adolescents, asthma approach, which is a school-based intervention for adolescents and medical providers. The study found that asthma helped improve self-management and reduced morbidity and urgent health care use in low-income, urban, minority adolescents.